Just to wake everybody.
Assalamu alaikum. I appreciate everybody being here. I'll try to be as brief as I can, being the last presentation of the day. Dr. Amr Al-Habib touched a bit about spondylolisthesis. I'm going to talk about it from the pediatric perspectives. So what I would cover is the classification of spondylolisthesis and what is the evidence for various treatment options that we have, whether it's surgical or non-surgical. I think Dr. Malik Veiling mentioned this in his presentations. I'm going to present you the best research evidence, but when you treat your patient, you always have to think of your clinical expertise and what are the patient values. These form the basis of evidence-based medicine that we should apply to our patient population. If I present you with this case, who's a 16-year-old boy who failed non-operative treatment, first thing you would ask yourself, what sort of non-operative treatment you're going to offer this patient? What sort of medication? What sort of physical therapy protocol? What sort of bracing? Are you going to use injections? If all of these fail, what sort of surgery are you going to offer this patient? Is it a fusion in situ? Are you going to do an anterior cage followed by posterior fusion? Are you going to do posterior fusion and interbody fusion cage from the back? Obviously, you have a lot of options. Are you going to fuse him to the sacrum or just L5, S1? Are you going to go to L4? So to answer these questions, we're going to talk about the classification system that Dr. Amr Al-Habib mentioned, and I'm going to be brief and touch on the points that would help us in the decision-making for such cases. This was developed by the Spinal Deformity Study Group back in 2011. And to understand the basis of this classification system, I'm going to take you back to this slide. As you see on the left, this patient have listhesis, and they have high pelvic parameters. Basically, their pelvic incidence, their sacral slope, their pelvic tilt is high. This was discovered by Lebel back in 2007 when he studied about 170 patients. He noticed that patients who have spondylolisthesis, they have high pelvic measures, pelvic incidence measures. Subsequent work by Rizzoli, he found a subgroup of patients. All these are retrospective studies, by the way. He found a subgroup of patients who have not a very high pelvic parameters, though they develop spondylolisthesis. Those patients are called the nutcracker type, and the ones to the left are called the shear type of spondylolisthesis. So the Spinal Deformity Study Group developed a classification system where they have 6 types of spondylolisthesis based on the two information I provided you. So they have a group of patients where the pelvic incidence is less than 45. It is the nutcracker type. In pediatric patients, those are the patients who have a dysplastic pars interarticularis of L5. As they go into movement, they develop the pars defect that will lead to listhesis. At least this is the theory. The second type are the patients who have pelvic incidence between 45 and 60. The third type are patients who have pelvic incidence more than 60. All these 3 types, usually they develop low-grade spondylolisthesis. If you go into the patients who have higher grade spondylolisthesis, they found 2 types. Patients who have balanced pelvis and patients who have retroverted pelvis. Those who have retroverted pelvis, they have the spine balanced or unbalanced. And I'm going to show you what do we mean by that. So now if you have a patient with high-grade spondylolisthesis, if you look at their lateral x-rays, they could have an anteverted pelvis, they could have a high sacral slope like the shear type, their pelvic tilt is low, so this is called balanced pelvis. As there are another type of patients who have a retroverted pelvis, basically they have vertical sacrum, their sacral slope is low, and after looking at that, they looked at C7 plumb line in relationship to the abnormality you see at the lumbosacral junction. This subset of patients on the right side, that line could fall between the femoral head and the center of the sacrum, then we call it balanced spine. Or it could fall in front of the femoral head, and we call it unbalanced spine. So basically, when you have, this is the summary of the classification system. The grade 1 is the low pelvic incidence, nutcracker. Type 2 is between 45 and 60. Type 3, when you have a patient who have pelvic incidence more than 60, all these are the low-grade spondylolisthesis. Type 4 is the balanced pelvis. Then retroverted pelvis, you look at the C7 plumb line. One question, why this C7 plumb line was not used in the previous types? Because in their study group, they found that all the previous 4 types, this line and the spine are balanced. So if you go into type 5 and 6, you want to assess the overall alignment of the spine in relation to the pelvis. One of the conclusions they have from their classification system, they thought that when you have a patient with unbalanced spine, those are the patients who may benefit from reducing their spondylolisthesis. But if you have somebody with a balanced spine, fusion in situ might do a good job. So that was the first part of my talk, and then I'm going to talk about the treatment options. These are the changes you see in your patients once they progress their spondylolisthesis. They have tighter hamstring, their iliofemoral ligaments, they become tight, and they lose that compensatory mechanism, so to speak. So what is the evidence for various treatment options? Looking at some of the systematic reviews which give good evidence about the treatment options for various things, this is from the adult literature. This is not a systematic review based on pediatric patients. But as you can see, reduction and instrumentation has a very low evidence. Decompression, we don't have, the evidence is insufficient to make any conclusion. There is a correlation of higher pelvic incidence and slip progression. The conclusion out of this systematic review is that in children, fusion in situ with long-term follow-up is recommended. But in adults, instrumented circumferential fusion provide the most promising clinical and radiographic outcome. There was a recent study that was published in Spine Deformity Journal back in September 2017, only 3 months ago, looking at this particular problem. This study was published from the Scoliosis Research Society. They have an evidence-based medicine committee, and they looked at spondylolisthesis. What is the evidence for various treatment options? One of the objectives of this study was to look at the future research opportunity for this type of problem. And I'm going to give you briefly what was the conclusion of their results. So they looked at about 6,000 articles. After they did their inclusion and exclusion criteria, 51 studies were included in this systematic review that I'm going to quote right now. Only 18 out of these 51 articles were level 3 evidence, and 33 were level 4 evidence. So obviously there is no level 1 or 2 evidence for the treatment of spondylolisthesis in pediatric patients. This is the first thing. So how do various treatments compare to the natural history of pediatric spondylolisthesis? They were talking about various treatment options, whether it's operative or non-operative. They concluded that there is a benign course is suggested for slip less than 50%. Substantial number of patients present for treatment for pain and activity limitation. Pain resolution and return to activity is common in both medical or interventional group versus the operative group. So patients return to their activities. Patients with high-grade slip with minimal symptoms could be followed up. So this was based on a small group of patients, about 5 patients who have a high-grade slip who were followed for a long time and they did not develop complications. Okay, how about the different pharmacological treatment? What sort of medication you want to give to those patients? What sort of physical therapy protocol you want to do? What type of exercises? If you want to use selective injections, is there evidence for these? Ancillary treatment, radiographic parameters, the mobility of the slip, the pelvic parameters I mentioned. What surgical method is cost effective? Is surgical treatment is cost effective? What sort of non-operative measures is the most cost effective? Have appropriate outcome measures being defined in this systematic review? Unfortunately, for all the things I mentioned, there is no studies that could be identified to answer these questions, or there is insufficient evidence. So basically what we do for our patients is, at the best, is level 4 evidence or based on retrospective studies. A few more things for the pediatric population. The role of interbody fusion in cases of spondylolisthesis is, at the best, is level 3 evidence. The role of surgical reduction is level 3 evidence. And I have to mention that based on the classification paper, we have to differentiate between reducing the slip, partially reducing the slip, or just correcting the slip angle. There is scattered report that if you correct just the slip angle, you are minimizing the risk of potential neurological complication and improving the overall sagittal alignment. So the conclusion of this recent systematic review, which was published 3 months ago, was there is a benign course for the slip, substantial number of patients present for treatment. So I'm going to go back to the case I just presented. So this patient had partial reduction. There was a cage placed, and somebody could argue that you could go, for example, in another case, from L4 to the sacrum. But even the evidence for extending your fusion higher or lower, there isn't data to support what sort of treatment you give to your patients. I'm going to stop here. Thank you very much.